Hello, hey everyone. This is a lecture for class of 2023 year 4 students, and this is probably the last to second last lecture in complete denture treatment planning, that is denture try in and insertion. So, moving on to the learning outcomes, you should be able to explain what a denture try-in is and what the denture insertion entails. You should restate the factors that govern the final determination of the vertical jaw relationship. You should apply the principles of the vertical jaw relationship, the centric jaw relationship, the phonetics, the posterior, that is the posterior parietal scene, and aesthetics at the time of the denture try-in. And you should also know the various factors involved in the failure of the denture, that is during the treat, and you should also be able to explain to the patient about the denture hygiene, that is maintenance care of the denture at the time of the denture insertion. So moving on, denture trying is the preliminary insertion of complete denture wax up to determine the fit aesthetic maxillomandibular relationship. A trial denture is a preliminary alignment of denture teeth that has been prepared for placement into the patient's mouth to evaluate the aesthetic and the maxillomandibular relationship. So basically, trial insertion or the denture trial is basically something like you would do for a suit or a dress. You give your measurements to the tailor, and before the final stitching is done, he will give you a trial of the suit or the dress which you intend to wear for a special occasion, to check whether all the measurements are accurate, whether the fit is accurate and to your liking. And then once you are satisfied, he will finish the suit or the dress. So, what is the importance of denture trying? It is a last opportunity to evaluate many previous steps like your jaw relationship, like your secondary impression. All these things are re-verified during this trial denture insertion step. It offers an excellent opportunity for the patient education and facilitate the patient acceptance of the finished processes. So this is a good opportunity to let the patient know what to expect from the denture, what are his expectations from the current trial setup that you have given him, and what he needs to do to take care of this denture, and what is needs to be done to be rehabilitated at the earliest with these dentures before the final process is finished. So it is more like a two-way communication between the dentist and the patient, and once both are satisfied, the denture can be finalized and the acrylization and finishing of the denture can begin. The objective is to verify the centric relationship, centric occlusion, that they coincide, there is no slide in centric, there is no open bite. You need to verify with the tooth selection, that is the selection of the tooth mold that you have selected for the patient, and the teeth arrangement is offers proper aesthetic lip support, cheek support, labial fullness, buccal fullness, all these things, and also to make additional interocclusal maxillomandibular record if you feel that there is an error in the centric or the vertical jaw relationship. Coming to the insertion of the complete denture itself, so as I mentioned, this is like a dress rehearsal or the dress trial, like in a company theater. The three aspects that need to be considered is the function as well as aesthetic acceptability of the denture by the patient as well as the dentist. The competency of the technical delivery, that is the technician's role, that is technician's skill, is also verified here at this step, whether any error has been done by the laboratory if the denture was sent to a third party lab for the fabrication. Various aspects are: first, we examine the denture extraorally, that is the trial denture or the wax setup of the denture is examined before placement in the patient's mouth. And the next is the intraoral examination of the trial dentures, that is you verify the aesthetics, you verify the periphery borders of the denture, you verify the centric relationship, centric occlusion, you verify the vertical dimension of occlusion and rest, and finally you also verify the phonetics, that is the patient's speech is not impeded, because remember, many of the patients who come to you for denture insertion are belong to a profession where they are active speaker, they may be active social activist, they may be a imam of a masjid, or they may be a pastor, or they may be a priest, or they may also be teachers or headmasters and principals. So speech is one of the very important reasons for which many patients come to you to seek the complete denture treatment. So it is very vital that your teeth arrangement or the teeth setup does not impede with the patient's pronunciation. The extraorally, you examine the denture flanges for the fullness, you examine the finishing of the wax setup of the denture teeth. There should be no wax on the teeth. It should resemble like a final setup that needs to be acrylized and finished. You need to verify whether there are any wax or any dirt or debris underneath the denture, whether there are any sharp edges that may hurt the patient and make him uncomfortable. All these things, and the proper sculpting of the wax that is proper, whether there is it is smooth, whether it the cameo surface and the intaglio surface meet over each other smoothly. It should meet like a fish belly. Next, coming to the intraoral examination. Intraoral examination, first is you need to disinfect the dentures with a proper disinfectant like formaldehyde or glutaraldehyde, and 10 minutes, or with spirit. You need to wash the dentures with soap and water before inserting in the patient's mouth. First, the mandibular denture is inserted, and then the mandibular denture is checked for various things like the peripheral border seal, the level of the occlusal plane, the lip fullness, the relief for the lingual frenum, and the space for the tongue. All these things are checked. Then the upper denture is inserted, and then similarly upper denture is corrected, checked for all these things like the peripheral extensions, the retention, the stability of the denture. All these things are verified in the maxillary denture. Then finally you verify your jaw relationship, whether it was recorded accurately, by verifying the centric relationship, by verifying the vertical dimension of occlusion, vertical dimension of rest, the Silverman's closest speaking space, all these things. And you verify the occlusal plane, whether the occlusal plane is parallel to the interpupillary line, to the alatragal line, whether the occlusal plane is canted towards one side, or whether there is excessive display of the teeth and the gums. So all these things in a nutshell are checked in the examination. So first, as I mentioned, you insert the lower denture, you check for the peripheral borders seal, and you check for the any underextension or the overextension of the denture flanges, which may indicate error in recording the secondary impression bottom molding. Then you check for the level of the occlusal plane. Then you check for the space for the tongue. Like here you can see there is the teeth are arranged in such a way that the tongue is large and there is not enough room for the tongue to lie between the uh, mandibular teeth arrangement. This will create instability. Then you also have to check for the alveolingual sulcus, whether it has been properly, the denture extensions are such that they do not cause the dislodgement or displacement of the denture. You have to check for the lingual frenum relief, especially here in Penang area, as we know that what I have seen in the past 2 months is that most of the patients have very high frenum attachment, or something which is similar to a tongue tie. So you have to give extensive lingual frenum relief for the stability of the denture. Next is we insert the upper denture. We similarly check the upper denture for the peripheral border seals. You should be able to see the mucobuccal reflection. That is the mucosal fold or the mucosal reflection from the vestibule should be visible. It should not be that the denture is pushing against the vestibular or the sulcus, and you are not able to see the movable and the attached gingiva. So the mucobuccal fold has to be visible just above the denture border. All the proper frenum reliefs like the buccal frenum and the label frenum relief should be given at this step, trial denture step, so that you show that the peripheral and the relieving structures have been properly, accurately recorded in the previous step. And of course, you also check for the aesthetics such as fullness, label fullness, all these things. And after peripheral extensions, you check for the retention. As I mentioned, as in previous lectures, retention is the ability of the prosthesis to resist displacement in a vertical direction towards the gravity. So we try to pull the denture down by holding it in a pinch grab between the thumb and the fingers, and you hold your fingers over the incisal edges of the anterior teeth, and you try to pull the denture to check whether the denture is retentive or not. Then the next thing is you check is the retention of the posterior palatal seal or the postdam area in the terminal part of the maxillary denture. So this is done by placing your index finger on the palatal surface of the maxillary central incisor and trying to tip the denture. So if the denture tips very easily, that means either your denture is overextended or the post-dam area it does not provide proper seal. So that has to be addressed and corrected. Then you put your index finger on the canine and then you try to tip the denture towards that side to check whether the hamular notches and the coronoid process have been properly recorded and there is proper retention in that area, that is on the opposite side. If you tip the canine towards the right side, then on the left contralateral side, the trigomandibular raphe, the hamular notch should have been recorded properly and the denture extraction should be accurate. Next, you come to the stability. To evaluate the stability of the lower denture, you place either finger on both the sides of the on the posterior teeth and try to tip the denture. That is, you lift one finger, press with one finger, then place the other finger down, lift the other finger, and you check that whether denture rocks or lifts or tips. So this could indicate again either poor record base or distorted base plate or the light acute record base, or it could also be that the posterior teeth are arranged too buccal to the ridge, resulting in the instability of the ridge. So then you have to arrange the teeth properly on the crest of the ridge. Okay, and then you check for the tongue space also. As I mentioned, tongue space is very important in stability of the denture. If the tongue space is not passively provided, then it will result in the instability or displacement of the lower denture. So the proper tongue space should be provided. The level of the occlusal plane should be just below the lateral border of the tongue. It should not be at the level of the tongue at rest. It should be below the lateral border of the tongue at rest. And you should make sure that many times what happens is when you have a smaller maxilla, in order to get a proper class 1 teeth arrangement, you try to arrange the mandibular teeth posteriors in such a way that they are lingually tipped. This result in the constriction of the tongue space. So this has to be avoided and it will create something like this. So as you know, I mentioned in the previous lecture, this is called as a pound line. That is a line extending from the lingual border of the retromolar pad to the mesial line angle of the canine. So on this line, the denture teeth should not encroach, but they should be arranged on the crest of the ridge. If you need to do a crossbite teeth arrangement, you can do a crossbite teeth arrangement for the posterior, but you cannot arrange the teeth in such a way that they encroach upon the pound line and finally they encroach upon the tongue space, resulting in instability of the lower denture. So as I mentioned, height of the occlusal plane should be just below the lateral border of the tongue and not above the tongue. This will result in instability of the denture, and ultimately it will also affect the retention of the lower denture. Next, coming to the verification of the jaw relationship records. That is, you need to verify the occlusal relationship, you need to verify the vertical jaw relationship, the centric or horizontal jaw relationship. So all these things are evaluated. This there should be proper maximum interscuspation of the upper and lower teeth in the what you call centric relation. That is, centric occlusion and centric relationship should coincide with each other. There should be not be any slide. That is, when the patient closes, there should be maximum intercuspation. That is, the class 1 occlusal relationship should be visible, and there should be no evidence of patient sliding the mandible from the centric position. This will create instability in the denture in the future. So you will check for the centric relationship, you will check for the proper intercuspation of all the teeth in centric relationship. If there are any errors, then you will take an intraocclusal record, and the mounting needs to be re-articulated on the articulator. Then you will correct the teeth arrangement, that is the occlusal relationship, and then you will finalize the denture. So you will check for the incisal plane, you will check for the occlusal plane, you will check for the plane of the mandibular teeth. All these things are verified along with the centric relation. So say this is a scenario where patient bites in centric maximum intercuspation, that is in centric relationship. But when you see the centric occlusion, you see that there is the posterior open bite. The teeth are not, this could be due to error in the secondary impression. This could also be due to an error most likely during jaw relationship step. That is, maybe the heels of the denture were touching prematurely before the wax rims came in contact, or the patient did not give a proper centric relationship, or the record bases were faulty and distorted, this could result in something like this. Also, if there is error in centric relationship, the midline generally shifts to one side after the patient closes, and then suddenly the jaw deviates to one side and the midline does not match. So this will give you an idea that there was an error in the recording of centric relationship. So this needs to be corrected by taking new interocclusal record between the upper and lower teeth, or in this case when there's an open bite, you can put softened wax here between the teeth, and you take a record of the of that side, and then you re-articulate the upper and lower teeth setting with the models. But for this, you have to make sure that your record bases are stable. Otherwise, you will again keep getting errors. Then you have also to check for the vertical jaw relationship. That is, a vertical dimension of occlusion is proper on both the side. That is, in right and left working side. So you place mylar strips or occlusal shim stock on the articulating paper between the teeth on premolars and molars on each side, and you pull it to see whether the teeth are in proper contact or not, whether there is occlusal prematurities or whether the teeth are out of occlusion. Many times the teeth may appear from the outside to be occluding with each other because of saliva and all these things, but they may not be in contact, and later patient may complain that instability of denture or inability to chew soft food on that side. So both the side you should have similar uh, pressure of the occlusal contact. So this can be checked with articulating paper or a shim stock. Next, after this, you have to check after horizontal and vertical jaw relationship record verification. You should also check the post-dam area. This is very important. Post-dam area, usually you will check and verify at the time of the secondary impression. You using a T-burnisher, you will palpate the posterior palatal seal post-dam area, and you will identify the anterior vibrating line, the posterior vibrating line, and the soft tissues, palpable soft tissues of the hard and the soft palate in this area. They are marked on the impression, and this transferred to the final master cast. And what many do is we can scrape this area to a depth of about zero point 0.5 to 1 mm. That is from the pterygomandibular notch on one side to the other side. Or we can simply create a post-dam seal by creating a simple groove in the post-dam area. So this groove will be filled by acrylic on the internal surface of the denture, that is integral surface of the denture. It will provide a positive pressure in the posterior palatal seal area and give a peripheral seal to your denture. This will improve the retention of the denture, or in some cases when the retention is not there, it will provide retention. So this is an important thing to check and to be incorporated in the final denture before the acrylization. Then you also need to check for aesthetics, that is proper labial fullness, proper, you should see whether the nasolabial fold is being obliterated or not. You should check for the proper cheek fullness. All these things need to be logged. Then you have to check for the incisal visibility in case of the upper denture. In older individuals, usually there will be only about zero point 0.5 to 1 mm of the incisal display of the upper anterior teeth. In some cases, there will be no display of the upper anterior teeth. Instead, you will have display of the 1 to 2 mm of the lower anterior teeth. This is because of the loss of support of the musculature and the sagging of the facial muscles and the fascia of the face. So, whereas in younger individuals or patients, say patients in their 40s who come for seeking denture treatment, in those cases, you should have at least 3 to 4 mm of incisal visibility. So all these things also need to be verified during the try-in appointment. After all, technicalities are not something which the patient is aware of. For as far as he is concerned, he just mainly looks for aesthetics and function. So next is speech consideration, that is phonetics. So phonetics is used to evaluate whether the position of the denture teeth and the contours of the maxillary palatal vault of the denture base are proper or not, because these will affect the various sounds like sibilants, linguodental sound, labiodentals sound, bilabial sounds, all these things. So first we check for sibilant. This is very easy. Sibilants are basically, you should remember, for S for sibilant. So any words that begin with S, that is when the upper and lower teeth come very near each other, that is the silverman's closest speaking space. So like when the patient says S So this results in the escape of air from between the palatal vault and the superior border or superior surface of the tongue, resulting in the pronunciation of S. So this is only possible when you have proper uh, minimum interocclusal space between the occluding surface of the upper and lower teeth. If this is obliterated, then patient cannot pronounce S properly. So you have to check for this. Then you have to check for labiodental sound. As I told you, labiodental sounds are sound which are made by the contact of the maxillary teeth with the lower lip, vermiform border of the lower lip. So if a patient is like words which include F or V, like fly or vault or all these, any words which has F or V in it, you need to verify whether patient is able to pronounce these words properly. If the maxillary anterior teeth are set too apically or too lingually or too palatally, then the patient will not able to pronounce F and V. So this will help you determine whether your upper anterior teeth arrangement is proper or not. And then bilabial sounds such as P for Papa, B for Bombay. So these sounds, if the patient is unable to make them, this means that the upper and lower maxillary and the mandibular anterior teeth are set too far labially, or the vertical dimension is increased. So in that case, either if the vertical dimension is increased, you will need to reduce the vertical dimension, that is by taking new maxillomandibular records, or if the upper and lower anterior teeth are set too far labially, then you will need to intrude them. So as patient is able to pronounce the bilabial sounds such as Papa, Bombay, all these things. So these are very important. So this is a table which shows basically what I told you just now. Like if patient has difficulty in pronouncing linguodental sounds or labiodental sounds, or what you call sibilants, or all these things, then you know what is the problem. And also you have to check for clicking of the teeth. If clicking of the teeth is there, that means the vertical dimension is increased, and or there is the denture are loose. While speaking, the denture slowly comes down, and the clicking of the teeth is heard. So all these things need to be verified beforehand. This is probably the most eager and anticipated step, especially for you guys, the final year and the fourth year students, because this is probably your first patient that you're doing a complete denture for, and probably the first interaction with a live patient in prosthodontics. So this is a huge step, and the complete denture fabrication is not for the faint-hearted. It is a very complex process. It is not as easy as it is seen or made to believe. So you have to be aware of the physical, physiological, and psychological needs of the patient that need to be addressed with the denture. And this appointment involves not only the clinical procedures but proper counseling of the patient about the expectations, about the training or getting used to wearing the dentures, and how to care for the denture. Because remember, it is a process just like any other processes, such as a maybe a missing hand, or a process for a missing leg, or an ocular processes, or a ear processes. Every processes has a lot of psychological and social impact on the patient, and if done properly, it can really help and benefit and improve and enrich the quality of life of the patient. So this step is really important. So next, coming to the denture inspection. After the denture acrylization, after the deflasking, you remove the dentures, you trim, polish, and finish the dentures in the laboratory. That is prior to receiving it in the clinic. And at this step, you first check the fitting surfaces or the tissue surface of denture for any imperfections, such as cracks, fissures, nodules, any sharp edges that may damage the patient's soft tissue and cause pain and discomfort. Secondly, you should inspect the borders, that the denture border, as I always tell, should be like a fish belly. They should be rounded from the tissue surface, that is the cameo intaglio surface, to the cameo surface, that is a polished surface. They should not be sharp. They should not be what you call flat. They should be rounded. And then thirdly, you'll inspect the cameo surface or the polished surface of the denture, that it should be completely smooth. They should try to achieve a glassy finish with some amount of gingival characterization and stippling and scalloping, if it can be done. So, and any plaster or dental stone that may be stuck at the interdental embrasures or the gingival margins need to be thoroughly removed prior to polishing. And next is, so this is how processed denture should look like. It should have a nice polished glossy surface with proper carving and scalloping and stippling of the gingiva. So next comes the intraoral adaptation. After you're thoroughly satisfied with the processed denture, it is ready for insertion in the patient mouth, and you need to insert the denture. You need to inspect the fitting surface of the denture, whether it has any premature or pressure spots on the patient's residual alveolar ridge. And these pressure spots are difficult to find out, because unless a patient has already worn the denture for a day or two. So one way to identify these pressure indicating areas or any sharp extensions is by using a pressure indicating paste. This is first applied using a brush or a cotton bud on the tissue surface of the denture. This is a highly viscous material which has thixotropic properties, that is, it will flow under pressure. So then the dentures are inserted in the patient's mouth. The patient is asked to bite on the upper and lower complete dentures, and then after some time, after a minute, the denture is removed and inspected for any areas where there is no pressure indicating place. That is, any areas that are exposed, like it may be at the border of the retromolar pads, or it may be in the alveolingual sulcus, or maybe in the anterior or the label under the label flange of the mandibular denture, or in the mylohyoid area. So any of these areas need to be seen. They should be marked with a pencil, and then the pressure indicating paste is removed, and these areas are trimmed or relieved. Similarly, the denture border extensions are also checked. So, as I mentioned, the border peripheries and seal need to be checked. If you have taken an accurate secondary impression, which is seldom the case in the clinics, because you all are learning, and it is difficult to get thorough impressions. So, denture extension, the flange extension into the vestibules, the relief of the labial frenum, the buccal frenums, the telecomandibular raphe, and the posterior palatal seal all need to be checked, verified in the patient. You can use a periodontal probe to place in the patient's vestibule and measure the vestibular depth, and then similarly you can also verify it on the dentures using the same periodontal probe, or you can just simply insert the denture in the patient mouth and do all the border movements like you do in the secondary impression step, and you need to check visually for the relief or overextension of the denture borders, denture flanges, all these things in the patient's mouth, and any discrepancy should be relieved then and there. So this is the what we are talking about, the clinical steps of denture insertion, verification, and so next is we check for retention and stability. That is by using a pinch method. We try to pull the denture away from the denture bearing area to check if it is retentive. And like I mentioned, a try-in appointment, we can check the contralateral sides retention or the border seal by placing a finger on the palatal aspect of the canine and then pushing the denture outwards. And so this will give you a fair idea about the retention and the stability of the denture. So this needs to be checked properly and thoroughly at this step. And also we shouldn't panic, because sometimes the denture may not be as retentive during the denture insertion appointment, but slowly in a matter of 3 to 4 days or up to a week, the denture settling happens. That is, the tissue or denture residual alveolar ridges, they mold or shape according to the internal tissue surface of the denture, because of the RELF or the residency like effect. And this in many patients, this will help in improvement of the retention and stability of the denture. So next step, also of course we have to check for aesthetics, the lip fullness, the labial full, the buccal fullness, and the incisal visibility depending on the age of the patient. And if the flanges are too thick, they should be trimmed and thinned out at this stage. Next, coming to the occlusion. So this is basically a very important part of denture insertion, as faulty occlusion will result in instability of the denture, will result in soreness of the denture bearing area, and will result in poor patient compliance. So the causes of occlusal discrepancy could be that there was an error in jaw relationship, that is there was slide in centric and maximum intercuspation do not coincide, and this you fail to check this at the trial appointment. Also, it could also be due to the errors in mounting. That is, while on mounting on the articulator, there was some displacement or shifting of the models with the wax rims, and this would also produce errors, changes in the supporting tissues, because the models that cast are made of gypsum, they are hard, whereas the denture tissues are soft and covered by mucous membrane and connective tissue. So because of the settling of the dentures, some errors in occlusion are definitely noted in the patients. So, and in some patients, there may be flabby tissues or knife edge ridges or bone resorption in certain areas that may cause the shifting and tilting of the denture base that is not actually visible to the eye, but it could result in errors in the occlusion. So these need to be verified, and the correction either can be done clinically by placing the dentures in the mouth and then and there verifying and adjusting the denture occlusal prematurities by selective grading. Or a more predictable method is what we call as a clinical mounting or a lab remounting. So here in clinical correction it is fairly easy. You place the articulating paper bilaterally on all the posteriors, that is bicuspids and the molars, and you take a bite in the centric, and then you tell patient to do eccentric movements, and you see whether all the teeth have uniform bite marks or the markings from the articulating paper. Because if all the teeth have markings, that means your VD is correct, and the markings for the mandibular posterior should be on their buccal cusp, and on the maxillary teeth it should be on their what do you call the palatal cusps. So these if this is not the case, then like here heavy occlusal contacts are seen on the maxillary posteriors but on the buccal cusp, which we do not want. So this needs to be adjusted by selective grinding using acrylic trimming burrs, and this can be done as I mentioned using articulating paper or by using softened wax and asking patient to bite in the softened wax, and wherever the wax is perforated, those areas are marked and they are selectively ground. We also have special articulating papers which are U-shaped for easy adjustment or ease of uh, correction of the occlusive prematurities, which can also be used. So what are the disadvantages of intraoral correction? See, the intraoral correction is a very straightforward and simple and quick step that can be done then and there at a chairside. But because of the resiliency and displacement of the supporting tissue, that is soft tissue under the denture, some premature contacts may not be visible at that time. And of course, it is not possible to observe all the discrepancies throughout the arch because of the poor visibility in the patient's mouth, the presence of saliva, and occlusal interferences can cause pain, which may make the patient avoid that side. So the patient may, if the patient suppose is having pain on the left side on the retromolar pad or on the tuberosity area, then he may not bite properly on the left side, and he may try to shift his mandible to the right side, and you may get occlusal heavy contacts or discrepancies more on the right side. So but this would actually not be the case if this discrepancies are being checked using a clinical mounting procedure. So the next procedure is the extraoral clinical remounting procedure. So in this procedure, basically what you do is you insert the dentures in the patient mouth. You first relieve all the painful areas or any overextensions and all those things. And then when you're ready to check for the occlusion, you take intraocclusal bite between the upper and lower complete dentures, and then you do a phaseboard transfer for, and then using the phaseboard transfer, the upper maxillary denture is mounted on the articulator, or if you already have existing or duplicate models of the patient, the cast, and you can just place the dentures on those cast and do the remounting using a phaseboard transfer. Then using intraocclusal record, the mandibular denture is also mounted, and then the balancing and selective grinding of the contacts of the occlusal prematurities is. So the basic rule here is called bull. That means buccal upper and low lingual lower. So basically, the as I mentioned earlier, the palatal cusp in the maxillary are the primary cusps or the holding cusp, and in the mandible they are the buccal cusp. So these cusps should not be modified because you will then be altering the vertical dimension of occlusion, and you will disturb the centric and the balancing contact. So that's why you have to modify the opposing cusp. That is, in the maxilla you will adjust the buccal cusp, in mandible you will adjust the lingual cusp. That's why it's called the bull law. So next, after occlusal discrepancies and selective grinding is done, you are satisfied, and then you have to give the post denture instruction, denture insertion instruction. That is how the denture should be inserted and removed, what all the patient should expect from the dentures. Patients should have a realistic expectation that a denture is a prosthesis. It is not their natural teeth, and they have lot of limitations, and they take time to get adapted to. So the all these things should be explained to the patient. Of course, you have to share the post care instructions with the patient also. So they should tell the patient that initially he'll have an awkward feeling, a feeling of heaviness, feeling of foreign body. There will be excess salivation. His appearance will be changed. He's not used to seeing his face like this because he has been edentures for a long time. His cheeks and lips have lost their tonicity, and now suddenly he feels lip fullness, cheek fullness, and the facial features they change. So, and his speech will be slurred and altered because of the palatal vault of the denture and the lingual flanges of the lower dentures, and because of the placement of the teeth on or facial to the ridges. So this will alter speech, and it will take some time to get trained to these things. So patient should be advised to read a magazine or a newspaper and practice to talk by looking in the mirror, so that he can get adapted better, because tongue is a very resilient muscle which has a very good memory, and it can be trained very easily to the speech pattern of the new denture. Of course, if there has some serious issues like pronunciation of sibilants, labodental sound, linguodental sound, bilabial sounds, these need to be corrected in the denture. But other than that, speech will fairly return to normal. And as I mentioned, there will excess salivary flow. So all these issues will slowly resolve over time. Patient should give at least 3 to 4 weeks to get adjusted to dentures. He cannot be impatient and cannot be unrealistic in his expectations of the dentist and the denture. So eating now, this is one of the major reasons that patients seek treatment for the denture fabrication, that they are unable to eat solid foods and their health has taken decline. So that's why you need to advise patients that they need to train first in order to be able to chew and eat properly. So this will usually take 6 to 8 weeks for him to be comfortable. Initially, patient should start with soft diet, like anything which is non-fibrous, non-chewy, and does not require too much effort. And any food that patient is eating, whether it is pizza or whether it is apple, banana, or any kind of fruit, they need to be cut into small bite-sized pieces and should be eaten with a spoon and fork. And the patient cannot bite directly into the food like he used to with his natural teeth. So, and the tissues first need to get used to the feel of the dentures, the pressure from the denture, because you remember the pressure is being transported from the denture to the denture bearing mucosa, and then from there it is transmitted to the underlying residual alveolar ridge. So, this is bound to create some soreness, ulceration, and discomfort and. So after all these things are done, recall is done, and the patient dentures are adjusted. You also need to give care instructions, like hygiene is of paramount importance. The dentures need to be brushed every day and cleaned every day, just like you would your natural teeth. But the difference being that dentures should be cleaned with a soft denture brush and not with a hard bristle brush, and not with toothpaste, but they should be cleaned with a mild soap or a liquid soap or soap wash. So, and the next thing is the dentures should always be cleaned thoroughly with water, and preferably a cleansing agent such as denture cleansers. Like all nowadays, all the denture product manufacturing companies, they make denture cleansing tablets or denture cleansing solutions. So basically, the denture should be occasionally placed in a water bath containing commercial grade denture cleansing tablets which are mainly contain sodium perborate, and denture usually can be left from half an hour to overnight, but it is preferable that dentures not be kept overnight, although I have written here overnight, but it is preferable because to not keep the dentures overnight, but half an hour is more than enough for the cleaning of the dentures. So another thing is that, and even in spite of cleaning the dentures thoroughly over the years, the denture may attract calculus and tartar and other deposits. So these can be removed by placing the dentures overnight in white vinegar, that is the regular synthetic vinegar which we get in the store shelves, and this will help in dissolving the calculus deposits. So this is with respect to denture care instructions, because remember, if proper care is not taken, then it will result in denture stomatitis, candidiasis, and inflammatory papillary hyperplasia, and all these conditions that affect the oral mucosa. So, as I mentioned, recall should be done first. Recall is done within the first couple of days, that is first 24 to 72 hours, and then second recall is done preferably after a week. And usually, patient will not have any complaint after the second visit. But if you desire or want, a third recall can be kept at 3 to 4 months, and yearly patient should come for the checkup and a thorough examination. Usually, dentures need to be replaced every 5 years, or at least they should be relined every 5 years, owing to the continuous resorption of the residual alveolar ridges underneath. So, with this, we come to an end. And in summary, denture insertion appointment is very important. I don't need to stress the how important this step is. And this is the culmination of all your efforts of the previous 4 to 5 appointments that you have been doing. And time spent by the dentist in this appointment will go a long way towards the success of the denture, because you see, a denture patient is like I would like to compare a denture patient is like a psychiatric appointment. You're not only giving processes to the patient, but you're changing his life, you're changing his quality of life, you're changing his smile, you are rehabilitating him, just like a prosthetic leg or a prosthetic hand rehabilitates a handicapped person. You are rehabilitating them. So with these things, with rehabilitation comes many social and psychological issues, and all these need to be gently addressed in each appointment. And in the final appointment, the expectations, the training involved, all these should be discussed with the patient, so that he is aware of all these things, and he is motivated and he is patient to overcome all these odds and have a successful denture. Because just success of a denture is not just in the hands of the dentist, but both the dentist and the patient determine the success of a complete denture processes, or for that matter any oral rehabilitation procedure. So thank you all.